Presenting the case of Mr. S. He is a 39-year-old gentleman, a resident of Bihar, studied up to post-graduation and is an accountant by profession with no previous comorbidities. Presented with complaints of swelling over bilateral lower limbs and decreased urine output for the past 6 days, with history of fever 8 days back. Patient was apparently alright 8 days back when he developed a fever which was intermittent, documented at 100 degree Fahrenheit, not associated with any chills, rigors, cough, cold, vomiting, or any loose stools. It was associated with generalized body ache, for which he took tablet azithromycin and paracetamol for 2 days, and his fever subsided. However, 2 days after the onset of fever, patient developed swelling over bilateral lower limbs, which was sudden in onset and progressive in nature. It was noticed by the patient by tightening of his slippers, and it progressed over the next few days up to his chin. The swelling was pitting in nature, non-tender, and the overlying skin was normal. This swelling was associated with simultaneous puffiness of his face as noticed by the patient's attendants. However, this swelling was not associated with any shortness of breath or chest pain. There was also decreased urine output along with swelling. This urine output was decreased in amount as well as frequency of passing urine as told by the patient. However, there was no pain while passing urine. There was no blood in the urine. There was no soap bubble appearance of the urine. With these symptoms, the patient got himself evaluated, and he was found to have a raised serum creatinine and was told that there was passage of blood and protein in his urines, as well as he had high blood pressures. With this, he was admitted outside, and he was started on antihypertensives where he was admitted, and his serum creatinine increased from 4.6 to 5.8 to 8.02 over the next few days, and this was associated with further decrease in urine output, and the patient told that the output was less than half a liter per day. This time the patient noticed that his urine had become high colored. In view of these symptoms, patient was dialyzed outside, and then he was referred to our center. Here on admission, his creatinine was 10 and he was dialyzed, and he then underwent a native kidney biopsy which was uneventful. Negative history. The patient does not complain of any throat infection or skin infection in the recent past. There was no history of joint pains, oral ulcers or hair fall. No history of rash anywhere in the body. No history of trauma in the recent past. No history of taking any painkillers. And no history of any abdominal or flank pains. Past history. The patient has a history of leprosy in 2019, for which he was treated for 2 years. However, there was no history of any hypertension, diabetes, or renal dysfunction in the past. His father is a diabetic, and mother has no comorbidities. He is married and has 2 children. Personal history he has no addictions, no alcohol, no smoking. He consumes 3 meals per day and has normal bowel habits and sleeps normal sleep cycle. However, for the past 6 days, the patient is experiencing a decreased urine output. Among the drug history, the patient took azithromycin and paracetamol for 2 days, 8 days back, and was given piperacillin and tazobactam for 4 days when he was admitted outside. There is no history of taking any alternative medicine. This is my history. To summarize, my patient is a 39-year-old gentleman with no known comorbidities, with past history of leprosy in 2019. Presented with complaints of bilateral lower limb swelling, decreased urine output for the past 6 days, and with a history of fever 2 days prior to the presentation, for which he took azithromycin. On evaluation, found to have rapidly rising serum creatinine levels requiring hemodialysis, and he then underwent a native kidney biopsy.
What are your possibilities?
Sir, looking at the presentation of the patient, he developed swelling and decreased urine output simultaneously. Also had high blood pressures and decreased urine output. So I would like to keep acute nephritic syndrome as my first possibility.
Acute nephritic syndrome. Okay, that's one possibility. Anything else?
Sir, unlikely, but we can also keep a possibility of acute interstitial nephritis, but the presentation does not match
Your
acute.
other differential diagnosis is acute interstitial nephritis.
Sir, I would like to keep it pretty low because the presentation is not.
अभी तो एक ही ऊपर बताइए आपने pretty low. I don't know. Then you say something about it, na?
So for acute nephritic syndrome, the etiological diagnosis, first I would like to keep infection-related glomerulonephritis because we have a history of fever.
अभी तो let's look at the possibilities first. You said acute nephritic syndrome, and then the causes of acute nephritic syndrome. You are thinking infection-related nephritis will come to the C3GN, IgA nephropathy, and then ankle vasculitis. Okay. What else? What are the other possibilities? So one is acute. What any other syndrome you would want to keep, or you feel that acute nephritic syndrome is the diagnosis?
Acute nephritic syndrome.
Is the diagnosis. Okay. Anyone wants to put any other possibility? No one wants to keep rapidly progressive RPGL. You don't want to keep RPGL? You keep or not keep? You not keep RPGL as a syndrome. Means differentiating acute nephritic syndrome and rapidly progressive glomerulonephritis is a different. Rapidly progressive renal failure is syndrome, of which RPGL would be the cause. So,
sir, it is usually from 2 weeks to 3 months, so a little insidious but this patient had a history. The progression of creatinine was from 4 to 8 within a span of 4 days. So we can say that acute nephritic syndrome causing acute kidney injury more likely than RPRF.
okay, we'll come to that. So, anyone for RPRF and RPGL or no one for RPGL? You would want to keep it. No, you will like to keep a possibility of a rapidly progressive renal failure as a syndromic diagnosis, and then maybe an RPGN as a cause for that rapidly progressive renal failure. Then you are now you can say that lower down up to now you are saying acute interstitial nephritis lower down. So you are saying these 4 causes of acute nephritic syndrome, and you're saying acute nephritic syndrome caused by acute interstitial nephritis or acute kidney injury caused by acute interstitial nephritis.
I was saying as a syndrome.
Syndrome is what? Acute
Interstitial.
That's not syndrome. That's not syndrome. Acute kidney injury.
Acute kidney.
So acute kidney injury. So that's the third diagnosis. What's second diagnosis? Now where we want to keep? You said you want to keep it lower down. So you want to keep it lower down. No, it's giving these syndromic diagnoses is extremely important because it will clear your thought process about the syndromes. And the reason why syndromes have been divided basically to narrow down the diagnosis so that you can fit it into the syndrome. So we'll come to these syndromes one by one and then see what are the holes which you can look at in acute nephritic syndrome, then why you think of rapidly progressive renal failure, and now you are saying the third diagnosis could be an acute kidney injury. And I think when you are looking at these at the time of history itself, always, I've said it earlier also, keep a broader differential diagnosis. Then physical examination and some of the tests might help you to narrow down these. So at this point of time, it may be good to keep broader perspective so that include more diagnosis. You may keep them lower down. You might say that I don't necessarily make it. I like to keep it lower down. But you're not yet, you've made one diagnosis and then you're saying next is acute nephritis, but I don't think it is so likely, then I like to keep it lower down. You haven't said anything. This is your second diagnosis. So lower down can only be if there are 2, 3 other diagnoses. Then you can say that okay. And acute kidney injury, you are saying acute intestinal. Any other possibility? Any other? Remote possibility now. But could he have had an underlying kidney disease which he didn't know about it, and this is an acute exacerbation of a kidney disease? vague possibility, which is possible, which will come out only after you've known some of the tests. So that can remain a possibility. Theoretically, yes, but practically, I don't think this is so. But as I said, that I don't want to be surprised later that his kidneys turn out to be smallish in size, and he had an underlying chronic kidney disease, and there was some acute exacerbation of the kidney. So I think those are kind of thought processes which should get into the mind of a person that yes, this is a young man who is well of a short history basically. Looks more like an acute, one of those syndromes. So all three syndromes are relatively acute syndromes, and then maybe he has an underlying asymptomatic chronic kidney disease, and then gets a viral fever, and that causes an exacerbation of the acute or chronic kidney disease. Whether this is interstitial on top of a chronic kidney disease, or it's just an acute hemodynamic effect, or maybe some infection-related infection on top of the underlying chronic. It could be a CKD or no chronic. Okay, take it. So now we like to discuss them right now, or maybe we can discuss them after we do the examination. That will give us better, maybe a perspective. So at the moment, anyone else with any other possibility? Anything else that one can think of? We'll come to these discussion on these possibilities somewhat later. Maybe I thought maybe a physical examination might give you some more clues too. Okay, go ahead, physical exam.
The patient is, I examined the patient on the day of admission. He was conscious oriented to time, place, and person. Height 163 centimeters, weight 78 kgs. His blood pressure was 154 by 90 millimeters of mercury, right arm supine position. His heart rate was 96 beats per minute, normal in volume character, and all peripheral pulses were palpable and equal. Respiratory rate was 16 per minute or abdominal thoracic. His temperature was 98 degree Fahrenheit. He was maintaining saturation of 98% on room air. There was no pallor, icterus, clubbing, lymphadenopathy. Pedal edema was present up to his shin with a normal overlying skin. There was no rash, no oral ulcers. Nails were normal, and there were no patches of hair loss. So systemic examination should have. It's
There wasn't
mostly
anything
normal.
else except that he had edema on that.
Yes. Urine routine microscopy showed protein 2 plus with RBCs of 177 for a high power field, and there were no casts.
With this urine, there was a urine routine also. This is microscopy only. 2 plus
2
protein.
plus is
Specific gravity.
specific gravity is
You didn't check it. You did a dipstick only.
Yes, the dipstick was done and then.
Or it is a urine report which you got from the lab.
I
You got it from the lab, yeah. So you didn't do the dipstick also. So that's the problem. So why is specific gravity important here? Why did I ask for specific gravity? Anyone else?
False.
Huh?
He's already originate. The specific gravity was high.
No, back up.
Protein plus can be a false.
Yeah. If you want to give some quantifying number to this 2 plus protein, it could vary because it's a qualitative test. It is not a quantitative test. Now 2 plus, 3 plus, 4 plus. You put 1 teaspoon of sugar in a cup, put 50 ml of water in it. So sugar will be maybe 200 milligrams. Now you put 50 ml more water into it, it becomes 100 milligrams of sugar. You put 100 ml of water, it becomes 50 milligrams. You put 200 ml of water, it becomes 25. Isn't it? So sugar is the same, but how much is the quantity of sugar? You will never know by its amount of water that is there along with it. That determines basically. So 2 plus, 3 plus, 4 plus will be determined not necessarily by the severity of proteinuria, but by also the amount of liquid or fluid that is there, or the amount of dilute, the water that is there in this urine. So one can be very, very different. So if it's an extremely dilute urine, then 4 plus proteinuria could be nephrotic vein proteinuria. But it's a highly concentrated urine, and 4 plus proteinuria may not be a nephrotic. So that's why you need quantification of the urine to get some idea that is it a dilute urine or is it a concentrated urine, or where is it in the concentration capability. You would want to know the specific gravity or osmolality. If the specific gravity is high, then 2 plus proteinuria may be consistent, and we will come as to why this is important in this differential diagnosis. So that's the reason why specific gravity would be an important point to look at, even if you did. So if I put it in, I would have wanted you to think that I will need a specific gravity because I'm going to discuss this patient on this number. And this number would require specific gravity to tell you, and that is where the differential diagnosis will come about. Okay, so we'll come back to that also. So specific gravity is something that you should look at. If it is done, I would these days, fortunately, you have a dipstick and many parameters are there in the dipstick. If it is albisticks only, then you may not have. But if it's a urine dipstick, then you will get it. Or somebody in the lab does it, and then they might do a full examination of it. But specific gravity is something that one should ask for. In that you would want to know it because many examiners will want you to create this differential diagnosis. Okay? So that's the examination. So your diagnosis remains the same. It doesn't change your diagnosis at the moment. The differential diagnosis remains you have an edema, blood pressure is somewhat elevated. Rest of the things are basically following. There isn't a large amount of ascites or so there isn't that kind of swelling at all. So your diagnosis basically remains the same. So let's now come to acute nephritic syndrome. What are points in favor of acute nephritic syndrome?
Decreased urine output, oliguria, hypertension. Now that we have the urine, hematuria, proteinuria, and acute onset. And edema.
He has fever. He has a fever. He has oliguria. He has swelling and
proteinuria,
hematuria, and he's hypertensive. He is hypertensive.
Onset is
he is hypertensive. But what is odd against this? What is against this? What is against acute nephritic syndrome? Typical acute nephritic syndrome would be a post-infectious glomerulonephritis, isn't it? That's what your first diagnosis is, a post-infectious glomerulonephritis. That would be the typical acute nephritic syndrome. So otherwise one will have to look at all acute nephritic syndromes, other diagnoses that you have put in that. They will not be typically, some of them will present, but they have many other manifestations also. So this is acute nephritic syndrome, but there are points against. This is not a typical acute nephritic syndrome. When is the fever, and what's the difference between the onset of fever and the onset of edema? Yeah, it's 8 days back he had fever, 2 days later he developed. So that's odd. It's not a typical post-infectious fever, isn't it? Normally, difference of about a week to 2 weeks, 10 to 15 days. Prior, somebody would have a fever, so odd feature. What kind of infections can still be, maybe they are there? Any other kinds of infections? Typically is a bacterial infection, a post-streptococcal, which is usually a skin infection or a throat infection. He doesn't have any of it. But any other infections can also give rise to a post-infectious glomerulonephritis. So any infections which could be consistent with maybe a fever few days earlier, and then the duration is smaller or lesser. What? You have myelofibrosis, maybe a bit relatively, but not really. Viral fevers, post-infectious viral infection. So if he had a viral, he had body aches. Yeah. So a viral infection producing a post-infectious glomerulonephritis still may be consistent with this kind of thing. Although it's also usually 4 to 6 days. It's about 2 days, 8 days and then 2 days. So one feature which is odd against acute nephritic syndrome is the onset of fever to the onset of oliguria, edema and other things. So somewhat odd. Anything else which is odd? Anything else which is odd? We give you the first opportunity. What's odd? How many patients of acute nephritic syndrome have you seen where creatinine is at presentation found to be 4 and then goes to 6 and then goes to 8? And by the time he comes there, it's about 10, 11, he needs dialysis. Short span of period. Acute nephritic syndrome, by and large, proteinuria again, it looks more that he was told that he has significant proteinuria. What's the degree of proteinuria in patients with acute nephritic syndrome? It's not nephrotic, is it? It's not nephrotic. So proteinuria is like RBCs and oliguria, red colored urine, red colored cast. Those are the features of. So if far greater rapid rise in serum creatinine going up to this, there may be a rise in serum creatinine, but it's very odd for a 8 days symptoms for people to have this rise of creatinine. So I think that this is doesn't fit into. So these are odd features of acute nephritic syndrome. So I agree that the first thought process from the history looks like that has some glomerulonephritis which fits in, but typical post-infectious glomerulonephritis looks a bit odd. Because one that the interval between the fever, the onset of the disease and fever is too short. Virus is still possible, but maybe I could still consider it if it is post-infectious than virus. But still, the rise in the creatinine, the degree of severity of renal failure is again odd. It can happen in a small subset of patients of acute nephritic syndrome. So, which are those patients where you can have a relatively
Rapid can be seen in C3 glomerulonephritis, anti-GBM can present very rapidly.
Yeah, anti-GBM can present, but those are again patients who have fit more into a rapidly progressive glomerulonephritis. So, acute nephritic syndrome or a post-infectious glomerulonephritis which has a crescentic nephritis, which will be again more like a rapidly progressive. But the cause of rapidly progressive glomerulonephritis or renal failure is post-infectious glomerulonephritis. So, that can present like this. But then the syndromic diagnosis would be more like an RPRF. So the very fact that the creatinine on day 6, day 7 is 4.8 is a bit odd for a typical acute nephritic syndrome to present like this. They present with volume overload, oliguria, some renal dysfunction, creatinine of 2, but they have far greater, some degree of proteinuria, 1.5, 2 grams of proteinuria, not. And the edema and all that is because of why is there swelling, oliguria and all that acute nephritic syndrome.
Hypoalbuminemia, negative on blood pressure, and also
That's not the reason for edema and no, not
hyporenism, hyporaldosteronism.
No. Oh, बहुत कहाँ जा रहे हैं? ये fundamental question है. This is acute nephritis is a fundamental question for a nephrologist. तो इसमें theory किताब पढ़ने से नहीं पढ़ा आना है. तभी तो मैं कह रहा हूँ किताबें कम पढ़ा करो और दिमाग ज़्यादा लगाया करो. Yeah, salt and water retention. There is a sudden decline in the GFR in patients because of the glomerular swelling and the endothelial swelling, and the mesangial hypercellularity. the endothelial cellular diabetes and increase in swelling endothelial. So the glomerulus becomes increased in size, sudden decrease in GFR, salt and water retention. That's why they get hypertension. Nephrotic syndrome, hypo-LP. They can. So the difference between acute nephritic syndrome and nephrotic syndrome can also have hypoalbuminemia. They have hypoalbuminemia, but they can also develop oliguria. So what's the difference between oliguria and acute nephritic syndrome and acute or nephrotic syndrome? Both have oliguria. Now what's the understanding of oliguria in nephrotic syndrome and oliguria in acute nephritic? When does it occur? Timing of acute nephritic syndrome. Timing of oliguria is early.
Earlier in nephritis.
Edema occurs later. So in nephritic syndrome, first decrease in urine output, then edema, and hypoalbuminemia develops very, very late. If albumin, the patient or usually acute nephritic syndrome will recover in 3 to 4 weeks time. So usually they don't develop hypoalbuminemia. But if it gets into a crescentic variety and all, then they might develop hypoalbuminemia. Then they have proteinuria, which is higher than nephrotic range proteinuria. Then they have crescents on the biopsy and could be still post-infectious. But that is the syndrome where they may have nephrotic syndrome in comparison have hypoalbuminemia as a feature and oliguria and occurs much later. So edema in nephrotic syndrome is much later. They have to develop hypoalbuminemia, and then that leads to salt and water. And that is because of what? Why is there increased salt and water absorption in patients with nephrotic syndrome? One? No, that is one. Anything else? One? No, not underfilled. किसी की ने पढ़ा नहीं है. Nephrotic syndrome में why is there increased salt and water? Anything to do with plasmin inhibitor factor activator? किसी ने पढ़ा? Sodium channels. There are hypoalbuminic patients who are analbuminemic. They don't develop edema. They don't develop. There are people who have no albumin. They're not edematous. They're okay. But patients with nephrotic syndrome develop hypoalbuminemia. And then they develop salt and water retention. So not because only that one is that hypovolemia occurs and then salt and the renin, angiotensin, aldosterone and all that. But the predominant reason for this is that what happens when you have albuminuria, the glomerular permeability to albumin is increased. So there is large amount of albumin which gets it gets filtered into the proximal tubule. Now this albumin needs to be, normally you pass 6 grams, 10 grams of protein, albumin in the urine. 2 eggs, 1 egg, 5 grams. You take care of this. But आप तो उसको कितना भी खिला लो, उसका एल्बुमिन को कुछ नहीं होता. वो क्यों नहीं होता? So there is much larger amount of albumin which is filtered into this. The one which is, lot of it is reabsorbed by the proximal convoluted tubule. And it is, what happens to it? It is catabolized. So it is catabolized. So how will you know how much is catabolized? How will you know how much is catabolized? Suppose you have to find out how much of albumin or protein is catabolized. So how will you know? What? How will you know? What happens to protein when it's catabolized? It forms urea. So how will you know how much? How do you know how much protein you or I am taking? How will you tell me? What? नहीं वो तो ठीक है बट पता कैसे चलेगा पहले 15% तो है नाइट्रोजन पता कैसे करोगे मैंने कितना खाया आपने कितना खाया इसने कितना खाया कैसे पता करोगे सही अरे यूरिया नाइट्रोजन बॉडी में कहाँ से निकलता है कितनी यूरिन से निकलता है ना सो डू a 24 hours urine for urea nitrogen and then multiply it by how much अरे भाई 16% है तो 100 में 16% 6.25 से मल्टीप्लाई करो टू कन्वर्ट इट इनटू प्रोटीन 6 टाइम्स से ज्यादा प्रोटीन होगा ना 16% of it is converted to nitrogen. So now to know, you calculate the amount of urea nitrogen which is excreted in 24 hours time. Protein nitrogen analysis जब करते हो तो how much is a patient, is he anabolic or catabolic or how much is known by doing a 24 hours urea nitrogen and then convert it into multiply it into 6 that will give you total amount of protein that you and I have. So in patients with nephrotic syndrome, in addition, many of these other proteins are also excreted or secreted or filtered into the because of the increased glomerular permeability. And then plasminogen, the amount of albumin that there's so plasminogen inhibitor activator is also, and that acts at the channels of sodium channels, absorption channels. So those are altered in patients with nephrotic syndrome because of those factors, and that's what leads to increased salt and water. Those there is an increased sodium reabsorption by the sodium channels basically. So that's the reason for salt and water retention. But hypoalbuminemia causes renal aldosterone, volume changes and all others also. In addition, there is increased salt and water retention which occurs later in patients with nephrotic. So nephrotic syndrome patients, the edema occurs much later. Is it? Occurs much later. Okay. So acute nephrotic syndrome, these are the points which are against it. Points in favor, the history is short. It's an 8-day kind of an event kind of a thing. But points against are the typical behavior of an acute nephrotic syndrome is not. A creatinine of 4.7 on day 6, 7 odd, very odd for an acute nephrotic syndrome. So therefore I have to think of something more plausible. So it could still be a post-infectious glomerulonephritis, but maybe a rapidly progressive renal failure kind of. So I would expect if it is RPGN, then it would be a crescentic kind of an RPGN. On a biopsy, I would expect it to be from history. There may be surprises in biopsy, but I would expect it to be a crescentic kind of a glomerulonephritis. There is no pulmonary involvement, and therefore an antibody, anti-glomerular basement membrane disease looks a bit unlikely. There isn't no history of a pulmonary, no exposure to drugs, viral illness is something, but still a short. But 8 days, 10 days, you never know. It could. And 70% people have only renal involvement, may not have lung involvement. So you might still think of this as an antibody, anti-GBM disease still. I can't totally rule out it in the RPGN kind of. So I think the points in favor of RPGN are
The
the
rapid
rapid progression of this disease. Onset is a bit odd. They are relatively not acute. They are subacute kind of, relatively insidious. Hypertension is again not as much a feature of rapidly progressive renal failure, but this degree of mild degrees of hypertension are not uncommon. Swelling is usually rapid progression of development of serum creatinine of 4 and then progressing very rapidly within weeks is quite in favor of the diagnosis. Finding of proteinuria and albuminuria with deteriorating kidney function favors a diagnosis of rapidly progressive kidney. So I would keep this after examination with the urinary findings and all that. I would keep it at a possibility slightly higher than the acute nephritic syndrome, although the presentation is. But I would still keep in the rapidly progressive glomerulonephritis, which will come to the causes of these stuff. So we could still keep a possibility of an anti-GBM as a mechanistic that rapidly progressive could be an immune complex mediated or a autoimmune also or an anti-GBM disease. So anti-GBM disease is still a possibility in this rapidly progressive glomerular. Looking at third possibility, AKI and an acute interstitial nephritis. This, as you were saying, looks less likely, and the other findings also now you are able to tell that this is very, very unlikely to be, because one, there is no history of drugs, there is no history of infection could be still there. He had fever, so is this an infection related acute interstitial nephritis? You can't still rule out. But degree of renal dysfunction would be again, but acute interstitial nephritis, especially infective etiology, you may not know. But his fever subsided. Usually acute interstitial nephritis related to infection and all, the fever would continue, be a feature which will be there for some period of time in the rapidly progressive renal failure. So you are talking of now not typically acute kidney injury as of a drug-induced acute interstitial nephritis, but rapidly progressive renal failure in which you have one cause is rapidly progressive glomerulonephritis because he has proteinuria, oliguria and other features. The other could be a rapidly progressive renal failure related to an acute interstitial nephritis. So that is another possibility which we can't totally rule out. I think we should still keep that possibility that it could be an acute interstitial nephritis, maybe an infection related because he had some fever there. There is no history of known drugs prior to this. He wasn't on any antecedent. So drug-induced looks. The fourth possibility we kept was a chronic kidney disease. The only is that it's a hypothetical kind of a situation that we, from the history, we don't have any evidence of chronic kidney disease. So what is, if you were to look at, does a patient, your patient have chronic kidney disease? Now what is it that you will ask him that by which you will know that maybe he has an underlying kidney disease? So what is it that you will want to know?
We can ask him about gradual weight loss, loss of appetite, darkening of skin, some urinary symptoms.
These are all features which you are wanting to find out hidden chronic disease, something which the patient is not telling you. So darkening of skin and all those happen much later in patients of kidney disease. So you are not saying that his creatinine was 4.6 because of chronic kidney disease. Obviously, it's something acute happening these 8 days which may have caused his creatinine to go up. So you are saying that he may have an underlying chronic kidney disease and this is an acute exacerbation on it. Now, how does one know? Could there be a possibility of an underlying? So, what are subtle signs of chronic kidney disease in early stages?
Nocturia, CI,
Nocturia. Good. So, you talk of nocturia. So, why is there nocturia in patients of chronic kidney disease?
chronic interstitial nephritis.
Yeah, chronic. Hypertension nephropathy. Chronic kidney disease because of diabetic nephropathy, because hypertension nephropathy, or interstitial nephritis, chronic glomerular nephritis. Why do people have Nocture.
Because ADH, which is normally produced more at night once we are
Something,
asleep,
something more
concentrating defect, urine
the
concentrating
concentrating defect because of what?
because ADH, which is supposed to which
ADH
surges
both
at night.
ADH both each other. Both each other. ADH. What else? But what? No, lack of concentration because of what?
Tubular gestation involvement.
What else? More important, fundamental to chronic kidney disease. Every patient of chronic kidney disease will have that, whatever the cause.
Increase in the
What happens to, how many nephrons are there in each kidney?
increased single nephron.
How many? One?
1 million.
1 million in each kidney. When chronic kidney disease occurs, what happens to these nephrons?
Number of
They keep on going down. Progressive chronic kidney disease causes. So the work which is done by these million nephrons are now done by 50,000 nephrons. So what happens to single nephron
it
glomerular
increases.
filtration?
Single nephron GFR increases.
So if the single nephron glomerular filtration increases, so what happens? What happens? What? So the amount of solute which has to be excreted by 1 million nephrons is now excreted by 50,000 nephrons. So what will it lead to? Solute diuresis. So that is the cause of lack of concentrating ability of the kidney. The lack of concentrating ability is because of solute diuresis. And what happens to the concentrating ability of the kidney is lost. It is fixed. What's the fixed at? Serum osmolality, the urinary osmolality will be what? In a patient with chronic kidney disease. What will be the urine osmolality?
Isostinuria.
What is urine osmolality? Kidney hogi. What will be the urine osmolality of a patient of chronic kidney disease?
Higher.
Huh?
Higher.
Decrease होगा.
दिमाग ही नहीं लगाते हो. That is the problem.
280 to
Yeah, it's the same as serum osmolality. Isostin क्या हुआ?
same as
Same as. So आप बोल तो रहे हो isostin uric, but समझ नहीं आ रही कि उसको क्या. It says the same that urine is not able to either dilute it or concentrate. So it's a fixed osmolality of the urine. So the specific gravity of the urine gets fixed at 1010. So normally when you and I pass urine, we pass how much urine in the morning and how much urine during the daytime and night time. Is there a variation or we have same urine? Daytime we pass more urine. Huh?
Passing is more, but production.
Production is less or more or so whatever. What is the diurnal rhythm of? What's the diurnal rhythm?
ADH production increases more at night.
Diurnal rhythm. What happens to urine at night? What's the capacity of bladder? तो ये सभी चीजें रिलेटेड है उसमें और ये किसी किताब में नहीं लिखी होंगी. जब आप किताब में पढ़ना चाहते हो अब एग्जाम के लिए तो कैसे होगा? इसमें तो नहीं लिखा है. What's the capacity of bladder? 350, 350, 400. अरे बताया क्या होता है? ठीक है, 350 to 4. ठीक है. So how much of urine do we pass in 24 hours? Roughly 2 liters, 1.5 to 2 liters. So we say for calculation purposes 2 liters. So ordinarily, if you are passing isostin uric, जिसमें ना आप यूरिन को concentrate कर पा रहे हो ना कुछ कर पा रहे हो, तो if you are passing 2 liters of urine, you will pass how much of urine per hour? Same urine, isn't it? Because you are not able to. If a patient of chronic kidney disease is passing 2 liters of urine, he should pass same urine during daytime, same urine during night time, because he is not able to concentrate. You and I are able to concentrate the urine at night, and although our capacity of bladder is 400, we need to, if we go at say 10:30 and we need to get up at 8 o'clock in the morning, the amount of urine should be such that we ordinarily don't have to. So each one of us, our bladders can extend. They may go to 400 and maybe 450, and most of us would pass slightly more urine in the morning. Our bladders are totally full, basically, because we have slept, and during sleep we do not get ordinarily, unless the bladder becomes very. So, in our normal people, because of the diurnal rhythm and the circadian rhythms and hormonal and other influences, the urine amount goes down at night, and we pass more urine during the daytime and it's more active. So we don't have to get up at night to pass urine, okay? Unless we sleep for longer periods of time. Otherwise, we should not have to get up at night. But a patient of chronic kidney disease is passing same amount of urine. It cannot concentrate the urine at night. It is passing same amount of urine. So what's going to happen? 1 liter, if he passes 2 liters of urine, 1 liter during daytime, 1 liter during night. So how many times should he have to get up? So you can predict it. You can tell him how many times. He will get up twice. Yeah. So he will get up twice at night. So a patient who has chronic kidney disease will tell you that he is getting up twice. कब से हो रहा है? मेरे को तो 6 साल हो गए. So you can, unless you also need to know that there may be bladder diseases or something else which may be the cause of chronic kidney disease, then these don't apply to those patients. So these are applicable only to people who do not have any lower tract disease. So people who have glomerulonephritis, hypertension, diabetes also later on, especially if it is prolonged and diabetic neuropathy, then you will have diabetic cystopathy and all others. They may alter all these kind of permutation combinations which go in your brain. But otherwise, you should be able to think that a patient with nocturia will have. So there is loss of concentration, and the cause of lack of concentration of urine is solute diuresis. Number one reason, solute diuresis. So this is the adaptation which kidneys undertake when the nephrons keep on dying. More and more nephrons in a progressive kidney disease. So there is an adaptation which occurs in the body. There is adaptation which occurs in the kidney itself. And you can see most of patients with chronic kidney disease, advanced kidneys, creatinine 6, 7, 8, 9, 10. Sodium, potassium, alright. Calcium, phosphorus, not too bad. So that's basically because of the adaptations that kidney has otherwise. Otherwise, you should have had significant changes in the sodium. Kidney is the major organ which handles calcium, which handles phosphorus, which handles sodium, which handles potassium, which handles magnesium. All of these should be altered. If the kidney function has progressively gone down, and it has gone down to a significant advanced disease, but kidney is still able to compensate and allow the human being to remain reasonably well asymptomatic, carry on all the activities, and this surprises. So the reason it should surprise everybody, and more so you, कि कैसे चलता है ये इंसान कैसे करता है, is because of this adaptation which occurs in these, the increase in the number of the function of single nephrons which occurs, and that's what is able to take care of it. And then there are hormonal changes. PTH goes up because the phosphorus is tending to go up. PTH tries to keep the phosphorus down till the number of nephrons go down so much that PTH is not able to take care of it, and the phosphorus starts going up, calcium goes down. So other things. But there is an adaptation of these hormonal axis as well, which is taking place. So there is a huge adaptation which occurs when a patient is undergoing. And all these adaptations are basically an attempt to keep this patient going on asymptomatically for fairly long periods of time. And the perturbations sometimes are created because of the alterations that you and I bring in. So then they get further altered because we give medicines, we do this, and the adaptations may get altered. Sometimes the natural adaptations which have occurred in these human beings have been very, very extremely beneficial, keep them alive. But the moment physicians come in, then they destroy some of this environmental adaptations which is happening, and that's where the problem starts. And if they remain all right, they may carry on for some period of time. But we intervene and do something else, and because we feel that we need to do something, and therefore sometimes these happen. So you need to be careful when you are wanting to alter this. Therefore, you can see that parathyroid hormone, which we thought, or even FGF23, which goes up very, very early. GFR 70, 60, PTH is also FGF2 first, and then as the GFR goes down to 50 or so, the PTH. You don't see it because the PTH remains higher, but phosphorus comes down and all that. But you see, these adaptations are important. Now, normally you feel PTH को तो बिल्कुल कम कर देना चाहिए, बोन सारे खराब हो जाएगा. But people have done FGF23, जैसे कि एंटीबॉडी लगा दो FGF23 पे सारा ठीक हो जाएगा शायद. तो people, though they gave it in animals, all the animals died. FGF2 was very important for the survival of these animals. So all the animals died because they wanted to check whether FGF23 monoclonal antibody could kill. So many of these hormones, that's why I was saying that adaptations occur in these because of the disease and the instinct of the body to survive, to keep the person, human being alive. So these adaptations are important. That's what. And it's very important for a nephrologist to go through these adaptations and understand these adaptations. So the cause of lack of concentration in urine is because of solute diuresis. Second, alterations in the ultrastructure of the interstitium and the kidney. That is what is called, so the IFTA and all other changes which occur. So if there is, single nephron hypothesis. Anyone has read single nephron hypothesis? आज की तारीख में adaptation नहीं पढ़ते ना kidney वाले. You read something about single nephron hypothesis? It's important especially for the single nephron glomerular filtration. What is single nephron hypothesis? Anyone? नहीं पता किसी. So single nephron hypothesis is that whether it is a glomerular disease or it is an interstitial disease which starts, if that nephron is damaged, whether it is interstitium of that nephron is damaged, then that glomerulus doesn't work. Or if that glomerulus is damaged, then that. So the nephrons which are working are intact nephrons. So it's the intact nephrons which work. Whether the initiating cause of chronic kidney disease was an interstitial disease or it was a glomerular disease. If the glomerulus is diseased, then that interstitium also gets diseased. So there is an architectural changes which occur in the kidney, this damaged kidney. What about the etiology of this? It doesn't matter. This pathophysiology and adaptation is irrelevant to the amount. There may be differences in the degrees of this adaptation, which might vary, but the adaptation is common to all patients of chronic kidney disease, irrespective of whatever the cause is. So what happens is that this nephrons which are working are the nephrons which are intact, and that's why there is increase in the single nephron glomerular filtration rate, and that nephron is working. And it does extra work. It absorbs more, it excretes more, it secretes more per nephron, everything is increased. And it tries to compensate for that decrease in the number of nephrons. Still it is able to do it. Then it gets over-exhausted and then it cannot compensate anymore. And then patients become suddenly very, very sick. So that's exactly what would happen in the patient. So it's important to understand this pathophysiology of like nocturia. So earlier symptoms of this would be a polyuria, which occurs in these patients because the number of nephrons have gone down. So there is solute diuresis which occurs in this. So large amount of solute will keep water. It doesn't allow the water absorption to occur, and the salt and water absorption occurs. It's like glucose not being absorbed, SGLT2 inhibitors. Glucose in the tubule keeps the sodium away, and there is natriuresis, diuresis and all that. So SGLT2 is effective. So same way. So there is an increased solute diuresis. So solute per nephron is more, absorption per nephron is less, of both salt and water. And so most chronic kidney diseases are, what are they? They are, so patients with chronic kidney disease are edematous or non-edematous? Why are they non-edematous? Why is it that patients with kidney disease, GFR 10, why should they not be edematous? Why are they not edematous? Because of, doesn't it strike you, you see everyday patients, chronic kidney disease, gives you a history of 10 days, he was perfectly alright, comes, you feel, now you're not sure whether it is RPGN, RPRF or it is chronic kidney disease. Now how do you distinguish it? How would you, chronic kidney disease would be what? How will it present? So you said that RPGN will be edematous. You said chronic kidney disease patients, you don't see them edematous. But why are they not edematous? They should be edematous. So what is it that keeps them not edematous? Anyone? Because of? No, but what happens to this? वो तो पेशेंट को समझाने के लिए तो ठीक है, बट आपकी समझ में कैसे हो जाता है? What do kidney do? If I give you a hint also. So, normal person you reduce salt intake to 10 grams. No salt for 10 days. Anna Azade, you go on a fast. नहीं हमारे सीनियर्स हमें बहुत तंग कर रहे हैं, हम नहीं करेंगे, स्ट्राइक पे चले जाते हो, अनशन करते हो, ये नहीं खाऊंगा, अन्ना आजाद 15-20 दिन नहीं खाया सॉल्ट. What happens to your urinary sodium?
Decreases.
Where? Decrease to what? No salt for 10 days, urine sodium 10 milligrams. So less than 10 milligrams. So your urinary sodium will go down. Put a patient of chronic kidney disease. So put a patient of chronic kidney disease, no salt for 10 days, 15 days. So what happens to urinary sodium?
Still be high.
Huh?
Still
It will be high. Yes, they are. Yes, there is natriuresis because of solute diuresis. I told you. So they are not able to decrease the sodium output. Yes, that's why they become volume depleted very quickly. So डॉक्टर ने कह दिया डायूरेटिक लगा दिया, ऊपर से कह दिया नमक बहुत कम खाना है या नहीं खाना है, and suddenly he comes with volume, severe volume depletion. Creatinine, which was 3 or 4 or 5, goes up to 10, 12. Because some good intelligent doctor said कि तुम नमक नहीं खाओ और यार नमक कम कर दिया, घर वालों ने और कम कर दिया, उसने सोचा बंद ही कर दो, and he comes back with severe volume. Because they are natriuretic, so they are salt losing. Chronic kidney disease is a salt losing state. That's why they remain, they don't become edematous and all that. Despite having proteinuria, hypoalbuminemia, but protein, because they are natriuretic. So natriuresis occurs in these patients. So fractional excretion of sodium in many patients of chronic kidney disease will be always, whatever the cause, diabetic, non-diabetic, otherwise. But otherwise, unless they are taking very large amounts of salt, most of these patients may not be. By and large, patients. And the differentiation between patients that will be chronic kidney disease is a very good clinical dictum. When you see a patient who tells you that he was well, but he is 6-7 days, same kind of history, 10 days history, 12 days, 10-12 दिन से उसको तकलीफ हो रही है, he suddenly finds that the creatinine is 6-7 and you examine him, he is totally dry, bone dry, chronic kidney disease, not RPGN. Although you say urine output come हो गया, because he's reduced his salt intake, his urine output has gone down, he's become volume depleted, he is dry. So it's a chronic kidney disease, not likely to be rapidly progressive. But clinical diagnosis, if you ask 20 out of 22 people, they'll all say this is rapidly progressive because the history is 10 days or 15 days or 20 days. But examination itself should tell you that this is a patient most likely of an underlying chronic kidney disease rather than. So this background should tell you that these patients are, how would one try to navigate and differential diagnosis of acute nephritic syndrome, rapidly progressive renal failure, acute kidney injury, and a chronic kidney disease. So chronic kidney disease, many of these features of polyuria and nocturia are very well. Then a background history of some generalized weakness, malaise, fatigue might give a clue. These are all non-specific clues. Polyuria, nocturia, if you have ruled out other bladder and other causes, then maybe a reasonably good indicator for saying that may be one of the reasons for this. Especially if there is a time to it that it was not there before. Many patients can say कि 5-6 साल से शुरू हुआ, तब से मुझे थकावट हो रही है. And then you must ask these patients exercise tolerance. Is this patient going upstairs? तेजी से जाता कहीं 2 सीढ़ियां चढ़ा, किसी के साथ भागा वो, उसको few years before. Chronic kidney disease is usually a slowly progressive disease. 3-4 साल पहले, 2 साल पहले, क्या वो भागता था? कभी सीढ़ी चढ़ा, ऊपर तेजी से चढ़ा, सांस कितना फूलता है? So those are the other questions which you should ask these patients, that so that you can unravel whether there is an underlying chronic kidney disease. So these are early signs of chronic kidney disease, and some of these need to be elucidated before you come to. And the purpose of predominantly this kind of clinical digging is basically to be able to analyze where you can fit into your possibility. So our possibilities now after the discussion look more to be like that this would be more like an RPGN, RPRF, RPGN as a cause. Most likely, could it be post-infectious glomerulonephritis? Probably less likely. But a viral post-infectious GN may not be still ruled out. Could it be an anti-GPM disease? Still possible. Could it be a post-immune kind of a glomerulonephritis? Still possible, although clinically there isn't any indicator for any other systemic kind of an involvement of vasculitis and all that. And the negative history should sort of look at these possibilities in your mind. So that's the. Now, what are the other odd glomerulonephritis which you had kept as a possibility? C3 glomerulonephritis can present like an acute nephritic syndrome. Many patients of C3 nephritis may just be like, they may be triggered by an infection, and many renal diseases are triggered by an infection, which could be nothing but maybe a viral infection or just a fever. So they may be triggered. Minimal change disease, nephrotic syndrome presentation many times is brought about by a small viral fever or some infection, sore throats. Children, you can see many children, their mothers will tell you, जिस वक्त इसका गला खराब हो जाता है उसी दिन अगले दिन उसका सूजन हो जाती है और प्रोटीन आना शुरू हो जाता है. So minimal change disease. Adults also same. Many times, many nephrotic syndromes are, the onset is related sometimes to an infection. So many infections, although the time frames in these are very, very small. So if there is already an underlying disease, then the time frame doesn't fit into that. They can suddenly become severely proteinuria, like minimal change disease. A sore throat and second episode and the proteinuria comes next day. It doesn't have to be a typical kind of a post-infectious what you see. So they become very quickly, suddenly proteinuria. So fever, time frame maybe. Then C3 nephritic disease could be an acute, just presentation like an acute nephritis. IgA nephropathy can also present like an acute nephritic syndrome. Crescentic glomerulonephritis, so presentation may be like an acute nephritis, could be like a rapidly progressive glomerulonephritis. In the crescentic GN you would find it, and it could be as a chronic kidney disease, just because IgA was not identified ever, and first time you see is nothing but chronic kidney disease, and the cause of it could be chronic. Many times the kidneys have become small, shrunken, and we may not be able to do the biopsy, and we will never be able to know. And many times you will know about that there may have been an underlying native kidney disease as IgA nephropathy when you do a transplant and you do a biopsy, and on biopsy you find IgA in a transplant kidney. And that might give you a clue that probably the native kidney disease may also, although it could be a de novo IgA also, but chances are fairly high in people in whom we haven't biopsied earlier that it may be it could be an IgA nephropathy. So those are. So what is the? So that's the others were ANCA vasculitis we talked about.
Can we keep lupus? Can we keep lupus?
You can't immune complex glomerulonephritis. When you talk of crescentic nephritis, then it could be an immune complex in which you have all the other possibilities. Obviously, lupus can be an odd kind of a thing, male, unlikely, less likely, but you can't rule out. And I think in a clinical discussion, you should say, although your examiners tend to push you to make one diagnosis or give you that what is this, that, and you should not necessarily get pushed into this. You could tell them that I will not be able to. The only thing is that you need to be confident to say this, but you should be knowledgeable also to say that no, it seems unlikely. I will not like to keep lupus as a possibility. But you not picking up this courage to say in the exam that no, I will not like it. But it's good to put a strong defense against your diagnosis and say it. And somebody pushes you that, like nephrotic syndrome, somebody should not tell me, is it minimal change of FH? You can tell him, आप बताइए सर आपको क्या लगता है, but आप एग्जाम में नहीं बता पाएंगे. So मैं तो कह सकता हूँ कि आप मुझे तो I will not be able to. It could be any of these. It is true that there is an incidence related to age, presentation and all that, but those are relative factors. A particular person may not have that. You can still have FHGS in an elderly person. You can have FHGS in a young patient. You can have MCD in a very elderly patient. So it's difficult to predict. If the picture is of a nephrotic syndrome, the three diagnoses are membranous, minimal change, FHGS. They will remain in these. Incidence might vary depending on which age you're talking about. Obviously, young child, minimal change disease would be the most likely. Then hypertension, microscopic immaturity, other features might help you to say. You can say one about the other, but you tell them that I will not be able to tell you. And that's the reason we do biopsy. If I knew if this was so, I wouldn't do a biopsy. Why do I do a biopsy? It's basically because of this. And you can say that. You will not get negative marks for this. Many people feel that they get negative marks. No, you need to be smart. You need to be also show that you are thinking with your brain. But during the exam, you seem to lose that confidence and therefore you get pushed. So don't necessarily push it. As long as you can say in certain diagnosis, like here, it's very difficult if you tell me, no, आप बताइए. अब आपको तो diagnosis पता है, शायद histology भी पता हो. Then you can push a person कि क्या बताइए और क्या, तो गिरा सकते, किसी को भी गिरा दो, निकलता है एंका, मैं एंटीजीपीएम पे बैठा हूँ या वो. So this is very extremely difficult clinically. If I knew this is anti-GBM, then I will not do a biopsy. Why would I do a biopsy? तो खेल के लिए थोड़ी biopsy करता हूँ. I need to know for sure that this is what it is, and all of us do that. So clinically, your job is, and you are being analyzed not to make a diagnosis. You are being analyzed for making a good analysis, whether you understand and whether you can make a logical discussion out of it. So that is what you are being tested for. So there is no need to look at whether you can make a diagnosis. If you make 3 differential diagnoses and can defend them, that I feel that this is still possible, this is still possible, this is still possible. And the only problem is that you're not experienced enough because you haven't seen enough cases and therefore you don't feel whether this fits it. But by and large, these 3-4 differential diagnoses get very difficult. You might put one above the other and there may be few points. And unfortunately, I feel that even for examiners there should be a docket of do's and don'ts. What is it? Some people push in, ये ज़्यादा common इसमें है, ये ज़्यादा uncommon इसमें है. I'm not very impressed with that. That if that was so sacrosanct, then again I would be able to make a diagnosis with that. But these are all so variable. 20% patients here may have this, 30% there may have it. So it's a matter of percentages, and where does patient fit in that percentages is very difficult to predict. So by and large, I would say that in the exam also you should be strong enough to say that, so these are my three possibilities. It's difficult to say which one is above the other. I'll keep all three and then use the kidney biopsy to find out what it is. So that will help you to sort of, and you will tell the patient also that this girl or this boy is a confident boy and is good. So you will not get negative marks. I can tell you this. Okay, chaliye aage. So what did we do? So
Investigation.
hemoglobin was 11.3. So it also rules out chronic kidney disease. Anemia would have been far more common in a patient who would be.
At the time of
TLC is 6,300. No, we will analyze all of them. So he doesn't tell you at least no active infection at the point. Platelet count is 1,50,000 and they're okay. Creatinine is 10.2, which is after how much of? He was dialyzed.
So he was dialyzed also and came to us, so he was not dialyzed for 3 to 4 days.
Okay. So albumin is 2.6. So acute nephritic syndrome would be again odd. An albumin of 2.6 if he was within 10-15 days. So albumin of 2.6 is, what's the half-life of albumin? 1 month. So at least 30 days. So albumin will not change that quickly in an acute illness. So and not a nephrotic. So this looks to be that there has to be a significant amount of. But acute illness sometimes can cause. Viral markers are negative, 1.2 gram, not too much of protein. So, but consistent with rapidly progressive glomerulonephritis, which is again don't have very heavy proteinuria again. Acute nephritic syndrome also can have proteinuria of 500 grams to a gram and a half. So C3 is 72. C4 is 8.5, which are both low. So 72 is also, C3 is also low, C4 is also low. So it looks more like an immune complex mediated disease or ANCA disease.
As negative, but
ANCA is
yeah,
negative.
as negative.
Okay, anti-GBM is negative, anti-DS-DNA is negative. So what do you think now? We don't look at the biopsy yet. So what do you think now? ANCA is negative.
I can rule out certain
Yeah.
diseases. So I can rule out IgA because C3, C4 is low. I can rule out ANCA.
IgA you can rule out because of?
Complements are low. Usually the complements are normal. IgA.
So IgA में हमेशा ही complement.
In
It's
cases
a-
of IgA dominant IRGN, we can.
IgA dominant IRGN उसमें C3 low होगा but not in IgA, so we cannot just rule out IgA now.
I would not necessarily rule out just on this basis that IgA is out. So I would see all of these parameters, like I said, in the differential diagnosis also are relative kind of. This happens in this happens in this. So it's a relative. So make a strong statement that I will rule out IgA in these kind of things. Don't rule out unless you're very, very sure. You have a specific marker for anti-GBM disease. So you say anti-GBM clinically also it doesn't necessarily fit in with many things. So you will say that okay, anti-GBM to me looks reasonably out. I would be surprised if it shows me a linear pattern on biopsy. Anti-DS-DNA is very, very specific for lupus. So you feel that clinically also there wasn't much of thing to think about lupus. ANCAs are negative, so again, severe disease, creatinine of 10.2. If it is related to ANCA normally, although there are about 20% people who are ANCA negative may have still ANCA vasculitis or vasculitis like ANCA but ANCA negative. So 20%, but still maybe doesn't look like that. So C4, C3 tells you that this is an immune mediated disease. And usually a classical kind of a pathway. So C4. So you will have to look at diseases which can cause.
Classical complement pathway.
So C3 glomerulonephritis looks out.
Out, yes, sir.
from this kind of a possibility. I will not still rule out IgA nephropathy in this. Yes, IRGN like looks maybe still a possibility. Okay. Anything? Anybody else? Any other interpretation of this?
Then classical was involved also cryoglobulinemia, but there were no systemic features suggestive of cryoglobulinemia. We did an echo which was normal, so not endocarditis.
Yeah, viral markers are negative also. Usually hepatitis B, C, cryoglobulinemia. So you don't have any other reason to think of cryoglobulinemia.
PSGN was also ruled out because classical system is involved also.
Okay, let's go for the biopsy.
Then we did a native kidney biopsy which showed in light microscopy 9 glomeruli. None of them was sclerosed and there was endocapillary proliferation. It had a lobular accentuated pattern. Interstitium had inflammatory cells. There was mild acute tubular injury and vascular system was normal. On light microscopy, IF showed IgG2 plus in mesangial and capillary loops and coarse C3 staining 3 plus in mesangial and capillary loops. IgA, IgM and C1q were negative and EM was not done.
C1q is negative.
C1q is negative.
IgA, IgM were negative. C3 coarse and granular deposits with IgG.
IgG and C3 both. So this favors infection related glomerulonephritis. Also there is endocapillary proliferation. So it could be classical complement part of MPGN pattern involvement of classical complement pathway. Most likely secondary to an infection.
That's when you said that you can rule out because C3, C4 is also negative, infection is out. I wouldn't necessarily not make because infection is a fairly broad, and many of these bacteria, viruses, and other organisms could be using different kind of pathways and all that. So making strong statements that this is one, and many of these pathways and many of these diseases may still not be known. So this looks, although the clinical presentation from this clinical presentation looks far more severe than it is, but this is known. This is known. The interstitium needs more detail. Sometimes what happens in glomerular diseases, the renal dysfunction may not necessarily be related to glomerular disease, but interstitial disease. And this has been studied by many people. They much better correlation with the serum creatinine degrees occurred because of tubular dysfunction, which many of these people had. And when glomerular disease recovered completely, like post-infectious glomerulonephritis, what remained in some of these patients, especially those who had deterioration in renal function to a significant extent, was that they did 1 year after the recovery of say infectious glomerulonephritis, they looked at the tubular functions, the acidification of the tubules, the concentration and dilution capabilities of the kidneys, and they found that many of these patients who were diagnosed with acute glomerulonephritis, these remained and persisted for some period of time, and even longer, sometimes some years later also they had. And the correlation occurred more with the degree of interstitial inflammation rather than the severity of the glomerular disease. So the kidney dysfunction which might occur in patients with acute glomerulonephritis may not necessarily be related to the acute glomerular. We didn't find crescents. Ordinarily we had expected that this creatinine going to 4 and then to would be very. The biopsy doesn't show us anything, no crescents and all that, so the creatinine is gone up. So interstitium needs to be looked at maybe much more effectively in this. So a nephrologist should look at more, especially in this kind of a biopsy. When you are looking at it, I would look at the interstitium also, because this looks to me an odd feature that why would creatinine go to 10 and 12. It has happened. It is not that these patients are not seen. And coming to this now, this is post-infectious glomerulonephritis, creatinine of 10. What is the long-term prognosis of this patient?
If it is in this case, since it is not a PSGN. So the prognosis is not very good. About 30 to 40% patients have some residual dysfunction later on.
No, is it related? This patient, same biopsy, creatinine 2. Same patient, creatinine 10. Another patient, we require dialysis. So another patient, same finding, similar findings on biopsy, and creatinine 1.2, 1.3. So prognosis in all three of them, all are post-infectious.
So
This patient you are suspecting is a post-infectious one.
this is
Maybe
very
a viral,
much,
it doesn't look like post-streptococcal, but it's a maybe some virus or some kind of clinical features also favored more of a viral infection. So what's the prognosis?
we can
Does
temporal-
serial chemistry, especially the serum creatinine, degree of severity of serum creatinine reflect prognosis or?
So the association of the infection with the injury. So if it is para-infectious, that is, it is occurred during the infection, the glomerular injury has occurred, then the prognosis is bad. But if it is occurring post-infectious after 2 weeks, it is a better prognosis. If the infection is occurred first and then after 2 weeks the glomerular injury has occurred, that is better prognosis than para-infectious. But not the degree of creatinine.
Anyone severity of creatinine and post-infection?
Requires hemodialysis on presentation, then there are still chances that they.
Yeah, but biopsy showing this thing. I'm talking about biopsy showing this thing. When you have biopsy now, biopsy showing this thing, serum creatinine, by and large, they will recover renal function. It doesn't matter how severe the creatinine may be, they should recover renal function. So this biopsy should show a reasonably prognosis. You found crescents and all that, then obviously the biopsy. Now, if you have crescents, suppose you had 80% crescents in this, and you have another patient, same degree of crescents, 80%, but non-infectious. Say crescents in encephalitis. So rapidly progressive glomerular nephritis related to infection, crescentic nephritis. Another person with another non-infectious crescentic nephritis. So same degree, which will be better prognosis.
Anka will be better.
Which will be better. कई बार क्या कहा मैंने क्या कहा होगा आपको जब जो भी दिमाग में आए उल्टा सोचो ठीक होगा हाँ infection carries a better. So crescentic glomerulonephritis of infectious etiology has the best prognosis, better prognosis, long-term prognosis out of all the crescentic. So it is now not those who have crescents in infectious disease have poorer prognosis. So what are the poorer prognostic markers in patients with infectious glomerulonephritis? So what are the markers which will determine poor prognosis? So clinically, what? One is presentation. You said that those who have para-infection related presentation do worse than those who have typical post-infectious kind of. Usually people with typical streptococcal infection have it, and therefore they have had always good prognosis. But sometimes in clusters of post-infectious glomerulonephritis, multiple etiologies might occur, and then prognosis may not be, and presentations can be very different. So that is presentation. Then degree of proteinuria. Okay, severely oliguric or anuric. Severely oliguric or anuric patients. Degree of proteinuria. Degree of renal function has not been considered to be, but there are some studies which have shown that the severity of rise in the creatinine and the degree of renal dysfunction might be a factor. But most typical studies which have been done in the past about the severity of renal dysfunction in post-infectious glomerulonephritis have not cited severity or degree of renal function or renal failure as a severity marker, as a prognostic marker. But crescents on biopsy, poorer prognostic. Not recovering within the typical 4 to 6 weeks time. So if you haven't recovered in 4 to 6 weeks time, that's again a poorer prognostic marker. So which usually happens in people who have degree of proteinuria is high, and the chances that you may have crescentic transformation in these biopsies or crescents may be present on biopsy, because many times you don't biopsy patients of and you might think that this is post-infectious glomerulonephritis will recover, and you might have to biopsy these patients if they don't recover. Now, if they don't recover, then obviously you will biopsy some of these patients at that point of time, and then you will know as to what the cause is. So, non-recovery of, or not a complete recovery of renal function, or complete recovery of acute nephrotic syndrome in about 4 to 6 weeks would be again a prognostic factor. So, in post-infectious glomerulonephritis, I mean, treatment-wise, steroids, no steroids.
Controversial at present. Steroids benefit has not yet been proven.
So, which study are you for?
There was a study done in Madras Medical College in 2020. They took about 57 patients, and it was a randomized control study. So they showed supportive arm versus steroids plus supportive arm, and they found that steroids were not effective. The p-value was not significant in both the arms, and the side effects were more in the steroid group.
So, what are the various immunofluorescence patterns, and does that also suggest prognosis or no prognosis? Immunofluorescence. What's the immunofluorescence in infectious?
So, sir, in immunofluorescence, there will be IgG and C3 in IRGN. So, sir, if C3 is dominant by more than 2 magnitudes as compared to IgG, then it is more C3 dominant glomerulonephritis. But prognosis wise, sir, IgA dominant.
What are the various patterns of immunofluorescence?
In the PSGM, there will be, according to the stages, so subacute, acute, and chronic. Subacute will have a garland appearance, and acute will have a starry sky.
Where are these deposits in acute post-streptococcal glomerulonephritis?
So in subacute state, they are in mesangium and in the capillary loops. So that is why it gives a garland kind of appearance. But if it is acute, it comes over the subepithelial area, giving it a starry sky. And then in chronicity, the mesangial deposits remain. So that is called a mesangial pattern of immunofluorescence in PSG.
Yeah, immunofluorescence sometimes gives a very typical kind of presentations in post-streptococcal glomerulonephritis. That's it. Any questions? So usually it should recover in about 4 to 6 weeks time, and you usually just need to give supportive care in a patient like this. Obviously, they'll need to, and usually urine output will go up as they start recovering, and just salt and water management and diuretics for management, especially in patients who don't require dialysis. So then they may still continue to have salt and water retention for some period of time. What will you tell them about food? उसको क्या खाने को दें?
Calories wise, we have to give them 30 to 35 kilocalories per kg per day. Fat should be less 30%. Salt about 2 grams per day. Sodium 2 grams, salt 5 grams. And protein 0.8 gram per kg per day. Albumin was 2.6, so 0.8.
Dialysis per
Dialysis the 1 per kg. But sir, he recovered. He recovered.
He recovered now. He started recovering. He's gone back and recovered. His
Sir,
creatinine.
we gave him steroids.
We gave him steroids. So steroids से जल्दी ठीक हो गया. हाँ ये कह रहे हैं कि भाई हमने साइंस में तो कह रहा है स्टीरॉइड का कोई रोल नहीं है बट हमने दे दिया.
Anyhow, 15 days पहले हुए
Fine.
and here also 15 days is anyhow coming up to 4 weeks. So whether steroid helped or not.
Yeah, that's the problem with clinical medicine, that you will never know that what is it that brought about recovery. And many times you feel that no, I treated with steroids, and you will get up and say that I treated with steroids and therefore this patient recovered and went home. But we don't know that if you hadn't treated with steroids, he would have gone home still and probably not have all the side effects of the steroids as well. So that's the problem with clinical medicine and experience that all of us gain, and over the years that we keep on feeling that this is what it causes. But we never will be able to know what actually worked in many of these patients. So that's it. Any other questions? So adaptation of kidney is something you should read. I don't know where you will have to go to some of the older articles. Actually, I think the newer Brunner Rector has also not given it in this fashion. Actually, the Brunner Rector which I read was by Neil S. Bricker. But those articles are old now. You will not be able to understand. But the adaptations which have been described, which occur, is a fantastic kind of a reading as to how nature has created this huge organ which is so, it modifies itself such tremendous fashion, and you get fascinated at how it's able to take care of all the abnormalities which could happen. They don't become acidotic. Acid base is something which is not otherwise taken care by any other organ. The body's adaptations to this happens till the very late. Many of us treat them with soda bicarb and all that, although again doubtful, although there are few randomized trials, small randomized trials which show that in chronic kidney disease there may be some slowing down of progression of kidney disease, but large randomized trials haven't. Observational trials have been favorable for soda bicarb, but if you look at really good trials on soda bicarb, no good data to show that. So adaptation by the kidney, even though they have metabolic acidosis, but it's a compensated metabolic acidosis by and large till the very late period of time. So again, adaptation, extremely good adaptation for acid base occurs. So fairly well compensated. Electrolytes are very well taken care of by and large, although very large. So adaptation is something that is extremely good. And studied by whom? Most. Who are the people who study? So, go and read about adaptation, renal adaptation to nephron loss. So you will find some articles on the net. Read that. That's important basically for understanding the fundamentals of how. One is that you should know physiology first of sodium, potassium, others, and then you will see how kidney disease affects all this and how pathophysiology is able to compensate by adaptation to all these alterations which should occur in the patient but still are able to carry on for long periods. Very good. And that also helps you to understand some of the symptoms that these patients have. Then you will be able to understand polyuria, solute diuresis, and all other things much more comprehensive. Okay? Sure. Okay.